Good morning, everybody. I'm going to talk about the impact of informatics in health information and health informatics on healthcare. How does informatics impact healthcare? And I alluded to that yesterday in my introduction to in my inauguration of the symposium, that the huge amount of data that is collected in healthcare allows for again, a huge set of research. But at the same time, if you use analytics in the right way, you can drive the health policies. And to drive the health policies is a huge task. You need to have solid bases. And that's where I'm going to focus on today. And so I'm going to give a little bit of a picture of what the health system in Saudi Arabia is like. Where did it start? A bit of a history. How did it evolve over the years? What challenges do we face today? And how does informatics and health informatics, how can it help in shaping the future of healthcare in Saudi Arabia? So if you look at the geographic distribution of the geographic map of Saudi Arabia, it's a huge country with 13 regions and subgrouped into 5, or rather grouped into 5 zones. And if you look at the population is quite condensed in certain areas, yet there are huge spaces, and there are scattered populations everywhere. So you got populations here, there, everywhere. They're not really in one location. And that in itself is a challenge because you can't provide healthcare providers in every area, in every small town. If you look at some of the indicators in Saudi Arabia, you'd see that the population growth rate is at about 2.5%. The physician per 1,000 people is at 1.1%. And the hospital bed distribution is hospital bed capacity is at 2.3%, 2.4 recently, per 1,000 rather, sorry, my apologies. And if you look at the total health expenditure, it has reached today 7% of the total GDP. This is a sudden increase over the last decade from 3% or 3.2% to about 7%. That's a huge jump. And even with that, we are not able to provide what we consider proper care across the board in an integrated way. So the answer here is not going to be in putting more money into the system, because if we grow in the same rate, in no time we will reach a 30% and then 40% of GDP, which is not sustainable. So how do we look for alternatives? How do we deal with this matter in an alternative, in a better way? This is a slide that shows the expected population growth, and if you compare 2010 to 2025, in 2010 we were at about 28 millions, and in 2025 we're going to head to 38 millions. That's a very rapid growth rate. And with the scarcity of resources of providers, that becomes an impossible mission. Now let's look at the distribution of healthcare per sectors. Today, the Ministry of Health and all of its facilities, including the medical cities, provide about 60% of the total healthcare, mainly in primary and secondary, and to some extent in tertiary. And if you look at the private sector, it's scattered across the board, but again, mainly in primary and secondary. It provides about 20% today. And other government sectors provide about another 20%. Well, what does that mean? It simply means that there are multiple providers that cannot be guided by the same policy unless that policy is a dominant policy that comes across the board. So how do we build that? If you look at the history of the country, back in 1932 we had 5 hospitals. Today we have about 464 hospitals, and in 2017 we will end up with about 500 hospitals. Looking at the number of beds, that has grown from 250 to about 77,000. That's a huge jump. And again, if you focus here, is a jump, and then there is another jump. But that impacts the economies. And it's not only the micro, but rather the macroeconomics. And if you look at, again, the number of physicians, we're talking about 1,100 physicians back in 1970 and 75,000 physicians. The majority of those, 75%, are expatriates. The medical schools have grown from 0 back in 1970 to 26 today, with about 6,000 graduates per year and severe shortage in training seats. And so we cannot train everybody that graduates from medical school today. We can only take about 30% of the graduates. Again, how can we use that challenge or convert that challenge to an opportunity? The disease burden, the same thing across the world: obesity, smoking, diabetes, cardiovascular, and stroke. And we see an increase in all the numbers across the board in all of these different disease categories and entities. If you look at the disease burden by DALY, or by the disability adjusted life years, we haven't made a lot of progress between 1990 and 2010. And if you look at the numbers, they're quite similar, apart from maybe in stroke a little bit. Now, is that going to be solved by building more beds? I doubt it. If you look at the rest of the world today, everybody is talking about an average of 3 beds per 1,000. Now, there are countries that go up to about 9 beds per 1,000, but they're very limited. And then there are the poor countries that have less than 2 beds per 1,000. But even the ones that have more than 3 beds per 1,000 are coming down now on beds, trying to leverage on technology to prevent patients from coming to the beds. So the answer is not to build more beds, even though we still need to build more beds, because we're talking about 2.4 today per 1,000, and the average international is about 3 or 3 plus. If you look at, again, the complexity of the provider's map in Saudi Arabia, and the blue color in each of the shapes here represents primary, the beige represents secondary, and the gray represents tertiary care. And if you look at Ministry of Health, which takes 60% of the healthcare provision, majority is in primary, a little bit in tertiary, versus, for example, King Faisal Specialist Hospital here, which is mainly tertiary, a little bit of secondary, and minimal, if any, in primary. And then you take the National Guard and the Ministry of Defense and Ministry of Interior Affairs and university hospitals and the private sector. But as you can see here, everybody has their own shares, or have their own shares in every level of healthcare. And it varies from place to place. And again, that adds to the complexity of having policies that go across the board. I like the question of the keynote speaker, the last question that said, how can we help Saudi Arabia establish a data repository that anybody can tap into? That is very complex, given the current healthcare map. Now, this is the ecosystem that has the providers, the regulators, and the payers. And if you look at it, today the Ministry of Finance is the main payer, with a little bit of payment from the private insurance. Ministry of Health comes here as a regulator, comes here as a provider, and that's another complexity. And then you have the Saudi Health Council, the Saudi Commission for Health Specialties, the Saudi FDA, CACST, and the Council for Cooperative Health Insurance. Now, there is no clear boundaries between providers, payers, and regulators in the country today. So you see, for example, a regulator who is a provider at the same time and actually provides the big chunk of healthcare provision. So there is a conflict of interest right there, and that's what the country is trying to move out of now in the new health transformation policy. I'm not going to go over this. These are the The charges of the different sectors, the Saudi Commission for Health Specialties is mainly concerned with training and education and licensing. And even there is a little bit of a conflict of interest that needs to be looked into from politicians' side, from the policymakers, that there is training, licensing, registration, and setting the standards and setting the exams and qualifying the individuals after they finish their training in healthcare provision. Now, there is a conflict of interest right there, but that is being broken down now so that we can get out of the conflict of interest. If you look at the Saudi Health Council, this is a council that was generated to ensure good cooperation between the different healthcare sectors, to ensure that policies are made across the board, yet it hasn't been as effective and efficient as it should have been. And again, there are ways now to look into this, and it will come into the new transformation. Now, thoughts are that the Saudi Health Council will move under the regulating body, be it the Ministry of Health or a consortium of healthcare supervisory bodies. The Council for Cooperative Health Insurance was generated or created in the first place as the vehicle for insuring citizens, and then because it got late in deploying its system, private insurance grew so fast that now it becomes difficult to get rid of the private insurance. And maybe again in the new health transformation that is taking place now, there might be a marriage between cooperative insurance and private insurance into an insurance consortium. Now, this is just adding to the complexities that we're talking about. So what are the challenges today? There is a growing population across the world, and in Saudi Arabia we've seen the numbers, and there is an increasing governance. There is governance for everything, and this is the time to build a data center where governance is being built. It's not at its maximum yet, so you can still build something to have a data repository and data warehousing across the whole country. The scarcity of resources, and we see that now. The oil prices are dropping, the international economics are coming down, and so on and so forth. And there is an increasing demand in quality. What we used to accept decades ago, it's not acceptable today. There are things that were the standard of care that now are unacceptable, and they become part of risk management. And what are the opportunities? Technology has advanced tremendously over the last couple of decades. We might not feel it because we grew into it. But if you get somebody from 7 or 8 decades ago to see what's happening today, they'll be shocked. They'll go nuts about what's happening. Population health is another tool that we can use. It's another opportunity that we can use to avoid spending more resources into healthcare in the traditional way. Care pathways are the best to ensure that disease remains at a primary care level and not proceed to secondary or tertiary unless it's needed. And then data and analytics is the answer to all of this. The more data you have, whether it's patient data, whether it's population data, whether it's individual data, whether it's hospital data, utilization data, whatever data you have, and you can put into the complexity of analytics all the way from descriptive analytics to prospective analytics. That is the only way that you can manage a growing population in the scarcity of resources and increasing governance and not as much healthcare provision or healthcare providers in the market. Now, workforce optimization is part of that, and financial optimization is part of that as well. I'm not going to get into the definition of health informatics. You guys know this more than I do. It has just developed over the years that now it's not only health informatics, but it's clinical bioinformatics, it's consumers health informatics, education research health informatics, and then under each one of these there are sub-specialties, and the list grows as we go. That just tells you that there is a tremendous need for informatics to guide policymakers in healthcare as to where to spend the money. This takes us to where the health informatics, what is the product of health informatics? It's basically big data. And big data, whether it's volume, velocity, value, or the variety, has to be managed in a way that would be very useful in maximizing the utilization of resources. Well, we talked about the analytics and the complexity of analytics. So how do we transform? And I'll give you some examples of how we transform. We transform from providing care to patient to care to the population, so that we control more and more patients, preventing patients from going into the disease complexity from primary, secondary, and tertiary through population health. Episodic care is very expensive. And so instead of episodic care, we'll create clinical pathways to take care of the patient from the beginning of disease to the end. And we need to look into the causes. We need to have research, and how do you build research without data? And we need to share the data. And again, this goes back to the same point of how do we build a platform of data where it's secure, anonymous, and relevant to healthcare provision, so that major decisions can be guided by the population data. Now, here's what we did at KFMC about 3 years ago. Well, we said we want to put all of this into a big machine driven by data and guided by patient experience. We want to compare ourselves to the rest of the world through the global comparators. We want to introduce change management to take care of all of that. And then we have talent management, predictive analytics. We want to make sure that all of this runs in an economic way, and we want to measure performance and manage it. We want to have a properly managed revenue cycle, even though today we're not paid by encounter, but we see that there is a move towards that. So what do? Again, we introduce elements into this big machine that is called Business Intelligence Office, that would predict the future of healthcare, not only in Saudi Arabia, but across the globe, and then guide the move of KFMC as a medical city today, and hopefully as a corporate in the near future, to deal with the changes in a predictive or even prospective way. Let's look at this is a regular healthcare model today. You have a hospital, a general hospital, a specialty hospital, a primary care center, specialized clinic, patient's home, transportation modes, a medical city or a highly specialized hospital, and a chronic care facility. And then there are the different transportation models. What's the current situation in Saudi Arabia? You have the medical cities, and there are 5 of them. 3 are up and running, and 2 are being built as we speak. And then there are the medical cities under the different sectors. The 5 I mentioned are under the Ministry of Health. And then you have the specialist hospitals and the general hospitals and the primary care centers. They're all scattered all over the place. And there are in huge numbers. You should look at primary care centers, a huge number of primary care centers. The minority of those are successful in running business. Integration, talk about none today. The patient at a primary care center needs a referral to go to the secondary care, and then a referral to go to the specialist hospital, and then a referral to go to the medical city. And these referrals are not based on population responsibility. Whoever can go to this place and get referred to this place, and then there, and there, and then there, is by a flip of a coin, whether he or she are accepted here or not. And that acceptance is subject to the decision of the consultant on call in that specialty. There is absolutely no binding here. This medical city is not responsible for providing health care to a set of population. It is based on referral. So the referral comes in, the physician on call will look at the referral and say, yes, come, or no, don't come. And then that goes into a black hole. Why did this patient get rejected? Oh, we've created an audit system internally, but we're not supposed to. We're not asked to create an audit system that looks at rejection and acceptance and why are we accepting or why are we rejecting. Because at the end, we're paid a block funding at the beginning of the year, and they look at the number of patients we treat at the end of the year. And as long as there is marriage between the two, nobody looks into the details. And who's lost here? What is lost here? The integration of healthcare. The reason the healthcare is disintegrated today is because there is no common platform where the patient data can migrate up and down or move horizontally. And so every element of what you see here have their own data set that they don't share. And there is no platform. There's no way to share them. And that's where we need you guys. So if we think about integrating all of this, how do we integrate it? The proposal today is that the medical city becomes the hub, and everything becomes a spoke. Everything else becomes a spoke. And then there is a command and control center that looks at all the data, that every bit in this whole picture is linked one way or the other to the command and control center. And then patient can move from between different places smoothly because of the integrated care and integrated data. There are problems with this system, I'll tell you in shortly. So what are the current challenges, let's call them? Governance is a challenge, multiplicity of providers, and we talked about that. The fragmented service, the lack of integration. The referral system, as it stands today, is a challenge. The silos of the three levels of healthcare. The distances is a challenge. There are three-tier system in Saudi Arabia, and we talked about it. The public insurance, the private insurance, and the self-pay. The workforce scarcity is a challenge. The incompatibility of data is a challenge. And the different EHR systems, the inefficiencies, the lack of data. Now, a lot of people would say there are different EHR systems everywhere. We're not the only country that suffers that. But we're at our infancy in electronic health records. If we can fix it now, but it would be in a better shape than trying to build an integration system. In an integrated healthcare system, I want you to look at this side here, the column on your left hand that has solutions, and see how many of those are underlined. And you would immediately understand why they're underlined. Because all of these solutions here relate to what you do. They relate to informatics. Whether it's teleservices, whether it's unification of health records, whether it's integration of an ecosystem, whether it's a hub and spoke model, the interoperability, the data center, the command and control center, all of these are dependent on proper health informatics and proper analytics. That's the business intelligence that I talked about, and it looks at basically every aspect in KFMC, but I'm not going to get into the details of that. So what are we trying to do here? We're trying to compile the extremes, basically put the two extremes in one basket. One extreme is we're developing patient experience in a way that would listen to the patient and have the patient participate in their care and be very happy about the care they are provided with. And at the same time, we're looking at productivity and utilization, proper utilization. If you look at it from a distance, you'd say, well, these are two extremes that you can't bring together. The patients want to stay in the hospital. You want to discharge them because you want to increase productivity. If you discharge the patient, they're not happy, so you haven't reached their patient the best experience. But if you take this, if you dissect this further and take it through a system, you can put all of this into one system that would ensure proper patient experience, good patient experience, to their satisfaction, and would ensure utilization at the same time. And that, I'm not undermining. It's a big challenge, but we're working on it. So we're looking for health integration to serve the customer who's in the middle of all of these layers of regulations and policies. And around that come the regulation in the outskirts of the ecosystem with governance and outcome-based performance and so on and so forth, and key performance indicators of institutions and physicians and healthcare providers. That needs a lot of data and information in informatics, and that's where you come in linking the KPIs to the patient through the data and through the provider. Then comes in the healthcare economics that would guide where to use the resources based on the data. And that's where the payers will drive the money. Then you look at the providers, and they're driven again by the payment that is based on the data, that is based on the regulations, and so, or that drive the regulations rather. And finally, you have the command and control center, which basically becomes the 24/7 CEO who moves resources from one place to the other based on feedback, immediate feedback in a data center with a huge dashboard, similar to what you see on NASA or similar organizations. Now, all of that needs a lot of change management, not only for the healthcare providers to understand, but also for the patients and the customers to understand. And that is a challenge by itself. The customer has to be part of all of this transformation, where the patient can enter their own data, follow their own care pathway, make sure that they are part of not only their own care, but part of the overall ecosystem of healthcare. Now, this is the ideal healthcare model, in my humble opinion, where the patient is in the center. That patient controls his or her data. They have a command and control center or a call center to call. That call center is related to a command and control center, that they can move the patient to the right facility or move resources to the patient. Now, that will depend on cloud computing, cognitive analytics, and so on and so, cognitive computing and data and analytics, and all of that is here in the background. This moves through satellites for better communication, and then this command and control center will mobilize resources between the different places to make sure that the appropriate service is provided to the right patient. Now, whether that is a primary care center or a polyclinic or a medical city or a chronic care facility or a general hospital, doesn't matter, as long as we move the right resources to the right patient and have the patient in the center of that circle, where the patient controls part of their data. The rest of the data drives the entire system. Thank you.